still being here, and we're here for our third lecture. I'm really pleased to introduce Mary Hill, who is with Nursing Administration Adult Patient Care Services, specializing in wound care and ostomies and continence. And there's her bio. She's recently here from UTMB, and she can tell a little more about herself if she'd like. There's lots of things. I like her passion of providing care and improving quality of life for those dealing with life-changing fecal and urinary diversions, chronic wounds, and prevention of skin issues, which obviously are real important for older patients.
Thank you. Thank you, everyone, for having me here today. Branya, our wonderful Branya here, volunteered my services, as she does on a regular basis. And this morning, you know, the third Wednesday of the month is our pressure ulcer prevalent study. So we were here bright and early this morning, running all over the institution, looking at everybody's buttocks and documenting pressure ulcers. So maybe a little punchy, but try to go with the flow here. We're going to talk. I'm going to, as Tony said, I recently came here. I've been here a year yesterday, April 16th of last year. I came all the way from Michigan, University of Michigan, there where I was a woundostomy nurse, and I started my woundostomy career there. I came down to Texas for the warm, and boy am I glad I did, because Michigan had quite a rocky year for winter this year. So all my family and friends are up there cold, and I've had a quite nice winter down here. So I'm liking that. And the people down in Texas are probably the nicest people on earth. Not my first time in Texas. I used to live in San Antonio a while back. So I'm coming back to Texas because I liked it so much the first time. So today, you know, I was asked to talk about quality of life issues with on elderly with colostomies, and I chose the name of fecal diversions because I think as we tend to loop them all together as colostomies, and there are some differences. We tend to think if it's poop, it's a colostomy. So we're going to talk about some of the different types of fecal diversions and the reasons that patients end up having them. Describe some challenges and areas of concern that the elderly have with learning their self-care, and discuss some interventions to improve their transition and quality of life. Unfortunately, we never know how many people are out there with ostomies. We do know that approximately about 800,000, they say. Data's not good because, as you know, we get most of our data from Medicare and Medicaid, and most of those things are looped under the surgery for the DRG, and so we don't actually know if their low anterior resection resulted in an ostomy or not. So it's kind of an estimate. And then there's temporary ostomies versus permanent ostomies. So it's kind of a fluctuating thing going on out there. But we'll talk about what is a fecal diversion. I mean, obviously you're diverting stool. Some of the terminology that goes along with that, which you'll hear commonly say, they're ostomy. An ostomy is actually the surgical opening created to divert the stool. Another common name is stoma. Stoma is the Greek word for mouth or opening. Very commonly done. But the name of the actual ostomy is determined by where in the bowel that the stoma is, or the surgical opening is brought through. So a colostomy is actually a stoma that's brought up through, or an ostomy that's brought up through the colon or the large intestine. And then the other common fecal diversion that we have is the ileostomy, which is primarily taken from the distal small intestine or the ileum. You can have a duodenoscopy or a jejunoscopy, but those are not, those are usually an emergent type thing or some kind of aberrant ostomy surgery created from fistulas or some type of bowel trauma. Not something a surgeon would commonly do for obvious reasons. So talking a little bit about the history of ostomy care, and this is kind of an interesting overview. Our earliest known ostomies were actually fistulas that happened spontaneously from people either had trauma to their bowel walls or maybe had Crohn's disease and they spontaneously opened. But somewhere around the mid-1700s, some physicians noticed that these people that got these spontaneous fistulas survived these awful bowel diseases. So that led them to start thinking, hey, maybe wonder if we could surgically do that and save people's lives when they come up with trauma or obstructions. Obviously, in the 1700s, now they did try it. There's a handful of physicians that did do it. But mind you, back then we didn't have anesthesia. I don't know how far laudanum went with cutting open your belly. I imagine it didn't do too well. But at the time when they were doing these things, obviously we had no way, there was no ostomy pouches available in the 1700s, so containment was a big problem. So some attempts were made, a handful of people survived for different periods of time. Obviously didn't have antibiotics back then either, so the history is sketchy there. In about the mid-1800s, about the time when we discovered ways to anesthetize people, all kinds of surgeries became more available. And so it started more ostomy diversions. But again, containment was a problem. Some of these first surgeries, all we have is descriptions of what attempts to contain the stool were. Some were described as sponges or adherent sponges that they held in place with elastic corsets. Imagine how smelly that was. Others were the sponge with a bowl covering it, and again the corset. There was talk about leather appliances strapped on and attached to glass bottles. I mean, they that's the mother of invention, necessity. So, but obviously, not very good ways to contain stool. So the surgeries did not, they were of urgent basis and last-ditch efforts. They weren't something that they proactively did. Ostomy supply companies didn't really start until about the 1950s. In 1924, a physician worked with a manufacturer to develop ostomy irrigations or enemas through the colostomy. And after that occurred, they did colostomies. That was the primary way to manage an ostomy, was to give yourself an enema, clean it out, and then do the absorptive dressing and the corset thing. And they also tried some interesting apparatuses to try to plug the hole. Metal, rubbers, try to put rubber stoppers in there, and obviously that didn't work too well either. The colon will find a way to relieve its pressure. And then after the irrigation, so from the mid-1920s until the 1950s, that was the primary way that people managed their ostomies, was with enemas. Once or twice a day, clean it out, try to use an absorptive type dressing, and to contain that effluent. Ileostomies, obviously, they tried doing them, but then found out that there are way too many complications and skin problems, so those were, only done as emergent. And you imagine dealing with solid stool, right? Try dealing with liquid caustic battery acid coming out of those rudimentary appliances. And then in the 1950s, we had Norma Gill, who was the first enterostomal therapy or wound ostomy nurse. She was she was not a nurse. She was a patient with an ostomy of Dr. Rupert Turnbull at Cleveland Clinic. And Dr. Turnbull noticed that Norma adapted very well to her ostomy and was pretty inventive about ways to manage it. So he had engaged her at some point to help him educate his new ostomy patients and counsel them and help them out. So she kind of developed her own little ostomy clinic out of her basement and struck up a relationship with Marlin Company, which was an ostomy company, and worked with them to develop new products. 1956, Dr. Turnbull and Norma Gill developed the first enterostomal therapy program of study. And then she was the director of that program at Cleveland Clinic for several decades. So that was the beginning of the ostomy nurse. And it's kind of my plug for walk nurses because this is the National Walk Nurse Week, February or April 14th to the 20th. So that was kind of the rudimentary history. So some of the early ostomy pouches looked like this. They were rubber, latex, did not control odor at all. I don't know if you've ever had stool or had some of the old rectal pouches that were rubber or latex. They sweated and you could smell, and the smell went right through them. So it was quite a thing. You had to clean it out a couple times a day. You always had to worry about odor, and you had to glue them on. They used rubber cement and cemented them on, and then had to use solvent to get them off. So you imagine the skin problems at that time. About the 1970s, they came out with a vinyl pouch, but they still had these, complicated apparatuses, and you still had to glue the thing on, and then you screwed this other stuff on, and it's still not odor-proof.
What is that, a metal, like
A guard,
oh, okay.
to prevent trauma there. That was one of the earlier attempts for that. Now they're everywhere. You got tons of things and accessories, and the interesting thing about that is most of the ostomy supplies were developed by ostomy patients, and then walk nurses, and the companies still to this day are very good about work. When patients come to them and say, hey, can you make a clamp to do this, or can we find something to do that, that's where all of these accessories and stuff came from, and they still to this day do that. And ostomy pouches, they're always constantly coming out with new products and better products. And the odor-proof pouch didn't come about to about the mid-1980s. So you think about, nothing really kind of happened between the 20s and the 50s, and then we got some things, but really, all of the technology for managing colostomies and ileostomies have come about in the last 30 years. So, and the reason I'm telling you that is because we're talking about elderly people. People that were born prior to 1950 have a lot of preconceived notions of what having an ostomy is. They have, people back then were ostracized. They weren't invited to Thanksgiving dinner, because how could you enjoy Thanksgiving dinner when, the strong smell of stool and gas in the room? And so there was a big stigma associated with that prior to those times. So if you have, if you're over even my age, I remember people, I remember a friend of the family that had an ostomy, and it was, we kind of wondered what was going on, and Uncle Bob never went anywhere. He stayed in the house, and he didn't join us for dinner and things like that. So there was a lot of stigma associated with that. And indications for colostomy and ostomy, the number one in the elderly age group is colorectal cancer. I mean, that's usually when cancer strikes. Diverticulitis is another one, trauma, car accidents, penetrating traumas, farm accidents, obstructions, another big one, and maybe ongoing inflammatory bowel diseases. Types of fecal diversion. So we're going to talk a little bit about what's the difference between them and why is it important to know the difference between them. And it has to do with management of the ostomies. When you have, think about what your bowel does. Your small intestine is where all your digestive processes are taking place. Your body dumps a lot of fluid in there, a lot of water, digestive enzymes. So it's it's liquid. It's very caustic. Ostomies that are taken from the small bowel are not going to be solid stool. They're going to be liquid. They're going to be caustic. They're going to be very caustic to the skin. You're going to need to worry about leaking, and you're not going to want these people to leak because digestive enzymes' purpose is to digest fats, proteins, and carbohydrates, and it doesn't know the difference between the steak you ate and your skin. So they do a very good job at breaking things down. Once that chyme comes into your large intestine, the job of the large intestine is to reabsorb all that fluid, your electrolytes, and neutralize those digestive enzymes. So as it moves along the large intestine, more and more fluids are reabsorbed, more electrolytes are reabsorbed. So where you are taking that stoma from can affect the dietary, can affect skin protection, the types of pouches you wear, the size of pouches you wear. So, a sigmoid colonoscopy is the most common kind. This is what you want to have if you're going to have a colostomy. It's most like your normal formed stool. It's less caustic to the skin. Unfortunately, it's more odor and more gas is also coming through there. If you have a transverse colostomy, which is across the top, your stool is never going to be solid like a sigmoid colostomy or a descending colostomy. It's going to be more mushy in consistency. If it's on this side, it might be toothpaste or oatmeal. Over here, it might be applesauce. If you go down into the ascending colon, or the first part of your colon, that's a very large diameter tube. It's still liquid, acts very much like a small intestine stoma. So if a problem's here and they need to take a stoma from there, they're going to go to the small intestine. It's a smaller diameter tube. It's easier to manage and pouch. This makes a huge stoma. It makes even a huger loop stoma. Imagining going through the confusion and pain and surgery and waking up with a softball on your stomach. Kind of scary. And then the ileostomy is the small bowel. You have liquid to loose stool. It's high in digestive enzymes, very caustic to the skin. And you have a lot more dietary issues related to having an ileostomy. And talking about older adults, you look back to school days, Erickson's stage of development. They are in that integrity versus despair, concerned about losing their independence, concerned about losing their spouse, may have health concerns, may have financial concerns. you know, they may not only be dealing with the stoma, they may be dealing with a potentially terminal disease, and, you know, dealing with a cancer diagnosis. And that, too, in older people can be quite a stigma, because, you know, they may not, you know, now a lot of people survive cancers now. 40 years ago, that was a death sentence. Or, you know, we didn't have the great, or they may have memories of losing friends and going through and watching them suffer through chemotherapy and issues related to that, and then losing weight and withering away and then dying. And I have a, you know, personal story goes along with that, because my father had lung cancer at the end of his life, but he was taken to the emergency room for a bowel obstruction. And come to find out, he had lung cancer with mets to his colon, and he refused treatment. And he refused treatment because, by God, he was not going to wear a bag, and he was not going to have chemotherapy because he had watched a close friend die of pancreatic cancer and watched the suffering and, again, the wasting away, the horrible side effects of chemotherapy. And then he had his own memories of people with colostomies. So some of the challenges with learning care as we get older, you know, they may be just overwhelmed. You know, it may be a sudden thing happening to them, and with all the other things going on around them, they're looking at body image changes, preconceived notions of what it means. They have reduced eyesight, maybe hearing impaired, maybe having short-term memory issues, making it difficult to learn new things. Problem-solving skills are not as sharp as they used to be. They may have arthritis and have dexterity issues, where there's an issue with cutting a pouch opening or peeling off that backing to the pouch. They tend to have more surgical complications and longer recovery times. And then coexisting health problems. You know, as we get older, we're dealing with high blood pressure, diabetes, heart disease. We may have spouses who are having health issues. People facing ostomies, you know, it's a big quality of life issue. This was a statement that was made by an ostomate, Barbara Skaghan. She does a monthly newsletter out of Minnesota. And she quotes, you know, "I spent the first year living with an ostomy thinking everyone could smell me. Every time I drove past one of the many Minnesota cow pastures, I was sure it was me." This is very common. This is very common. I see this all the time. They worry about they're going to smell. The first several months, that's a big major concern. Or they'll ask their family, "Can you smell me?" You know, before they walk out the door to go to the grocery store or church, "Can you smell me?" It's one of the biggest fears and quality of life concerns. They're afraid that, and you know, that someone is going to smell them. Now, you think about that. We all poop. We go in the bathroom, we sit down, we take a poop, we wipe, we flush the toilet, get up, wash our hands, and go about our business. Many of us don't ever look back there. We get out of the bathroom as soon as possible. When you have a colostomy, that sucker's right up under your nose. It's on your belly, you gotta look at it, you gotta smell it, you gotta deal with it. So it's kind of right there in the center of their lives. The second biggest fear that they have is fear of leakage in public, or fear of leakage period. This is one of the big things that keep people in their house. Did I go? What did I do? Especially if they've had issues in the hospital with leaking, because in their minds, they're trying to learn this stuff. If the nurses can't get the pouch to stick, how am I ever going to get the pouch to stick, you know? So it's very fearful. Body image changes. You know, they're dealing with, you know, poop's not supposed to come out your belly. Social isolation because of these things. And if these things are happening in the beginning, is you know, that will lead them into isolating themselves and staying home. They also fear nobody's going to want to be with me. Nobody's going to want to hug me. No one's going to want to sleep with me. If they're single, you know, nobody's going to want to marry me if I have an ostomy. They may be dealing with changes in diet, which can be hard. If you're 80 years old and you've ate the same thing for all your life, it's kind of hard to change those routines. They may have financial concerns with dealing with obtaining supplies. If they're an established ostomy, you know, they may be managing this thing for 40 years, but all of a sudden they've got health, they're not healthy, they're weak, they may have arthritis, their skin's sagging, now their pouch is leaking. There's age-related changes that come with growing older with an ostomy, even when you've been managing it very well throughout your life. For a new ostomy, these are basic skills that they need to leave the hospital with. They need to be able to use that clamp, because even if they can get a nurse to come in and change the pouch, or a family member to change the pouch, they're there with that pouch all day. They've got to be able to open it and close it and empty it and burp the gas out of it. Care of the skin and stoma, how to size and properly change their pouch. Dietary considerations, especially with an ileostomy, which we'll go into a little bit, and how to get their supplies. They have no clue as to how to get their supplies. They'll often ask me, can I get them at Walmart? No, they come from a DME company and they require a prescription. So thinking about interventions, how do we help them transition through this? And it is a transition. You know, it gets better. One of the big things that you can help with your patients, no matter what your discipline is helping to get rid of those myths, debunking the myths, reassuring them that their life is going to come back, letting them know that the appliances now are odor-proof, that we have deodorizers that we can put in there and neutralize those odors, and let them know that it's a learning curve. Don't be hard on yourself. You know, getting the right pouch fit, you know, sometimes takes a few different tries and, you know, working with some different things. So especially the first 3 months after their surgery, they're dealing, you know, they're in a high anxiety state. So, you know, they don't care about how the great procedures were and, you know, how great the surgeon was. What they care about is, am I going to be able to play with my grandkids? Am I going to be able to play golf again? Will I ever go in a hot tub again? And the answer to all those are yes. An ostomy patient now in this century, in the 21st century, should be able to transition back to the life that they had before, or very close to it. There is no reason that they cannot unless they have a medical or serious illness to where they can't. And we need to let them know that. We also need to be mindful of how we approach them, especially when they have a new ostomy. And you know, we talked about the smell fear, the smell factor. One of the worst things we can do as caregivers is to tell them that they stink. And we can do that. We don't necessarily have to use words. You know, the facial expressions say it all. You know, and you open the pouch and you go back, or I've heard nurses say, "Wow, that stinks." And even if they're a humorous patient, you know, inside they're shrinking. You know, that's a horrible, horrible reality for them. Intimacy is another big factor. And the statistics show that people who were married when they got their ostomy stay married, and they transition back to a life very much like they had before. The intimacy thing is a big reason why people refuse ostomies. And it's not something that they easily will discuss with their physicians either. That's, coming from the background that they come from. But I have been sent or consulted to talk to patients who are refusing surgery. And oftentimes I find this is one of the big reasons. And it just is about, getting the ball started, opening the discussion. Patients tell me everything, you can imagine. But not too long ago, I was consulted to counsel or educate a lady in the hospital who was refusing life-saving surgery for colon cancer. And she was retirement age. She was 66. Didn't look it. Very active woman. Still worked. Still did all kinds of activities, like to dance on the weekends. And she was like, absolutely not. I'm not going to have an ostomy. And come to find out, it was because she had been divorced for 5 years, was lonely, had been dating, didn't have anyone special, but that was a big part of her life. She did not want to be alone. She felt if she had to be alone that it was, not worth living for. And she may not have been told, but she heard someone say she would never have sex again. And so I asked her, did the surgeon say that you're going to lose your uterus and your vagina? Well, no, but I heard someone say that I'm not going to be able to have sex again. And who's going to want me, with a colostomy bag? Nobody's going to want me then. So what she heard was, or what was said was, there will be a recovery period where you wouldn't have sex, just like if you had a hysterectomy, 6 weeks, or if you had a baby, no sex for 6 weeks. But she heard, that's over for me. And she was very vibrant, 65 is the new 45, isn't it? We just are not aging like we used to. So people who are coming into, their retirement years, many of them are still very vibrant. They're out dancing at the clubs, they're playing golf, they're taking cruises. These are very important things for them. I had an 80-year-old gentleman who had bladder cancer, different set of organs, but he was refusing surgery because the same reason. And I think, nobody approached him or even had that discussion with him because he was 80 years old. What are you thinking about? You're 80 years old. But he and his wife had a very active sex life. And that was a very, very big issue for him. And no one had even thought to discuss with him nerve-sparing procedures. With the technology we have nowadays, they can use robotics and do nerve-sparing procedures so that you retain that function. Not in everyone, it depends on where the problem is, but it was never thought to be discussed with him because of his age. And that became a very big issue for him. And then it started a discussion with his surgeon, and he ended up getting a nerve-sparing procedure and went ahead with it. So, don't think because people are elderly that, that they're not intimate anymore. Teaching strategies as people get older, we need to take into, what their limitations can be. First of all, assess their readiness to learn. In surgery nowadays, colostomy surgery, they're in there for an average of 5 days. Think of post-op, you're 70 years old, post-op, a big abdominal surgery. The first day, you're not even out of anesthesia. You're practically comatose. Day 2, you may still be on that PCA pump and not very alert. Day 3, you get your bowels, 3 or 4, get your bowel sounds back. They start eating you and they shove you out the door. There's not a whole lot of time for them to learn things. So we need to say, are they ready to learn? If they're not ready to learn, then we need to engage a family member and have them come in and learn the care so that when they go home, they can coach them along. That's one way that I help break that up. This part is very difficult to do, breaking education in manageable sessions. Sometimes I don't have time to do that. And again, you have to engage the family, teach the family the care, and have the family teach them or coach them as they go home. Ensure adequate lighting. Make sure, some people as we get older, our vision is low. Use short, simple sentences, speak slowly and clearly. Use simple and familiar terms. And talk on their level. Use verbal, written, and visual clues. Include written instructions and larger print so that they can see it if they have vision problems. As much as possible, allow them to practice. And this is something that we don't really do real well in the hospital. And part of it is that the nurses, we as nurses are caregivers, and we want to take care of them. We want to do it. We feel like we're burdening them if we have them empty their own pouch or empty the gas out of their pouch or change their pouch. But actually, this is their time to practice, where they have someone to coach them, someone to back them up, someone to help clean up the mess if it becomes a mess, and encourage them. They need encouragement, because this is a bathroom procedure. This is the same as you and I going to the bathroom and taking care of ourselves. It's a simple bathroom procedure, but it's alien to them. So I encourage you, if staff on the floor, read the ostomy nurse notes. If you're not at this facility in the future, you have an ostomy nurse, read the note, because I'll usually say, the bedside nurse is to assist the patient with changing the bag, or emptying the bag and burping the bag and using the clamp, practicing using the clamp. And that's very important in the post-op area. Some of the roadblocks in the early times is the readiness to learn again. Hopefully they'll have a support system and a supportive family that's going to help. Surgical complications, pain can be an issue, and the short lengths of stays are roadblocks to learning new ostomy care. Established patients that are coming in, they may, again, be having problems, and they may have been doing their ostomy care for 30 years, but now they're getting older and their skin is sagging and the pouch is leaking, and they don't realize that you need to change the appliance needs to change. The equipment needs to change when your body changes. When you gain weight, when you lose weight, when your skin starts sagging, things need to change. So if you're seeing a patient in your setting and they're and they have an ostomy, ask them. They may not have seen an ostomy nurse in 20 or 30 years. Ask them, how are you doing with your ostomy? If your patient is not getting at least 3 to 4 days of wear time with their ostomy, they need a different appliance. So the equipment needs to change. So I have a couple case studies here to go over, and one I chose an ileostomy because I want to show some of the challenges that go along with a small bowel stoma, and the other is a colostomy. And these are real life people. Well, not her. We're going to call her Emma. She is just one of those Google-free elderly ladies. But we'll call her Emma. Ms. Emma is 83-year-old African-American female with an emergent ileostomy surgery. which was related to severe bowel ischemia. So it was an emergent type thing. She comes into the ER with abdominal pain, vomiting, and she wakes up with an ileostomy. And she was mad as a hatter. She was not having it. Miss Emma was a very independent 83-year-old lady. She was still taking care of herself. She was still taking care of her home. She was driving. She was shopping. She was going to church. She was very active in her church. She was like the matriarch of her church. She normally did walking and fishing, and she often talked about fishing off the pier near her home. And for 83-year-olds, this is still a very active lady. And she had some other, she had some arthritis and some other things going on, high blood pressure, but still pretty much taking care of herself. She has an adult son who resides with her. However, again, she's very reliant and she's very modest. Matriarch of the church, very modest. She does have a housekeeper that comes in and helps, that they pay private duty. Her initial reaction to her ostomy, of course, was shock. She was angry. She was terrified. Nobody told her that she might wake up with an ostomy, very, very tearful, very fearful that she was not going to get her life back and she wouldn't be able to take care of herself. Her son, who lived with her, due to her modesty, she would not even let him be anywhere near the room when the ostomy was being changed or even emptied or burped. She didn't want him, she sent him out of the room, and he jumped up and ran out of the room. So she was not able to, due to her arthritis, was not really able to manipulate the pouch well, and she was still shaky and still kind of groggy and confused from the surgery. So she arranged to have her housekeeper come in to help learn the care for her, because she didn't want the son to be involved in that personal kind of business. So so we taught the caregiver. She went home with him. Within a week and a half, she was back in the emergency room due to dehydration and high output ileostomy. Now, this is what happens with an ileostomy. This is the most common reason that people come back to the hospital after having an ileostomy. Dehydration and electrolyte imbalances. Going back to where we talked about the ileostomy in the bowel, it's liquid. We educate them. If it's coming out of your bag, it needs to go back in your mouth. You need to replace those fluids and electrolytes constantly. And there are ways to use food to help do that. We've all heard of the BRAT diet, bread, bananas, rice, applesauce, those type of things to help bulk up stool and help slow down that transit. They don't do it. She's 83 years old. She doesn't have very much appetite after going home. And then she starts eating her old diet, which is a very Cajun diet. Lots of gumbo, fried chicken, spicy foods. And that old ileostomy just went wild. Ileostomy's gone wild. So, of course, they get weak, they get dehydrated, they're back in the hospital. And what's the first thing that providers think? The ostomy pouch is exploding off, she's got diarrhea all over the place. When she was just in the hospital, she must have C. diff. So we work her up for C. diff, they do some scans. 9 times out of 10, it's dehydration. They haven't replaced their fluids, they haven't used the food to try to slow down that bowel transit. And then when she comes in with explosive diarrhea, what do? Put her on bowel rest. And that doesn't work for ileostomies. We need to bulk the stool and slow the transit time. So we need things like Imodium, Metamucil to help bulk up and absorb that fluid and slow down that transit time through bowel, replace the electrolytes. And the other thing that they do is, you know, stuff's coming out, the pouch is leaking, so they stop eating, thinking, well, if I'm not eating, nothing's going through there, nothing's going to come out. And the bowel just is not, it's not having that. It's not having the gumbo, because 3 days ago you were giving it Jell-O. You know, so it's ileostomy's gone wild, and now, you know, she comes in a week and a half later, 10 pounds weight loss, dehydrated, weak, and even more, you know, the ostomy's been leaking, so she's scared to death to go out of her house. And then she comes in with this high output ostomy. The nurses can't get it to stick, it keeps blowing off, and so they decide to just put a pad there and let it leak through the night, wait for the ostomy nurse to come in the morning. And she is horrified by this. By the time I get there the next day, the skin's broken down, she's in tears, very depressed, you know, saying over and over and over, my life is over, my life is over. So, and then so she kind of come in and out of the hospital, same type of thing. You know, she was re-educated on her diet, but she would say things like, you know, I'm 83 years old, I've been eating, this has been keeping me alive for 83 years, you know, it just needs to adapt. Now over time, the ileostomy will adapt and will take on some functions of the bowel and start reabsorbing things, but it takes some time down the road. You know, how do we help someone like this? You know, this is a lady, you know, who was very much in charge of her life, very, very fastidious about her home, about her appearance, and you know, and now she's terrified to go out of her house. Her pouch is leaking. So number one, you know, we need to, you know, get a pouch that sticks on and help her start building some confidence in her equipment. Address the body issues. At some point, she has to realize that she's not, that she needs help and she needs to accept help. So eventually she does, in an emergency, had to help her, let her son help her, and it was just horrifying for her that he had to come in the bathroom and see her like that. Very, very hard. So, you know, and it takes time. It takes time, and you know, and she did get into a pouching system that was working better for her, and you know, and she's only about 6 months out, so you know, she's still a work in progress. But this is very common with an elderly with an ileostomy. Case study number 2 is a colostomy. Now this lady, we'll call her Mary Ellen, 72 years old, she's married. She's had her sigmoid colostomy for colon cancer for 4 years. And she came into clinic for a follow-up with her colorectal surgeon, and because she was having issues with her pouch, and she had a hernia, and she had peristomal breakdown, so she was sent over to see me. She was a bit disheveled, very flat affect. So that she sometimes has to change her pouch daily, sometimes 2-3 times a day. Again, feels like she stinks all the time. She also has a husband who's disabled that she's responsible for. Her stoma is not the best construction. It's kind of sunk in. She has an obese abdomen, and she has a hernia that's complicating things. She's still using the original pouch from the hospital. The same old standard post-op pouch. No filter, so she's having to constantly open the pouch, let the gas out. She had no follow-up with an ostomy nurse after surgery, so she's 4 years out. And when asked, she said, well, you know, I just figured I had to live with it. This is it. So again, social isolation. She didn't do much. Quick trips to the store. She moved out of the bedroom because she was worried that her husband was going to be offended by the smell. Very depressed lady. So, you know, again, counseling. ostomy counseling, making sure she's got the appropriate pouch with a filter. Anyone with a colostomy who is at least 8 weeks out should have a filter. That's a charcoal filter that allows gas to escape slowly and deodorizes it, so they're not constantly having to open that up and into the air. Never heard of odor or odor neutralizer, so we got her some of that. And then once her confidence is gained, and this is a relationship, but these people have relationships with their ostomy nurses. They don't just walk out the door and never, they got my card. So, and you got to work with them and encourage them to return to their activities. Okay, now you're getting a 4-day wear time. You can go to church. You can go to church. And then sometimes we need to refer them out or encourage them to get some help or counseling or maybe some treatment for depression. But this is long going, this is 4 years out. So when we're looking at quality of life indicators for ostomates are what we call people who have ostomies. Several different studies from different institutions are done, but pretty much consistently shows that people are, if they've had a lot of symptoms with their disease process before surgery, their quality of life scores may be low. At 2 to 3 months, they're at the lowest, because that's when they're in that learning curve and that denial, anger phase of grieving and trying to learn their ostomy care. Around 6 months, we start to see some improvement. By 6 months, they've gained some confidence and some skills and figured a way to accommodate that in their lives. And then usually at about a year, you see a marked improvement. Now, as far as quality of life, we talked about some of the bad things, but sometimes the quality of life is improved vastly with an ostomy surgery. You have a patient who had long-term Crohn's disease or irritable bowel disease, and they're in the bathroom every 30 seconds and go in the bathroom 40 or 50 times a day, and stomach cramps and pain and bleeding rectally. Those patients often say their life's improved. I've even had 26-year-olds who come in with Crohn's disease and ileostomy, and when their surgery was going to be reversed, they refused it because their life, the quality of life had improved so much with the ostomy. So not always a bad thing, sometimes it's a good thing. Resources. We have the United Ostomy Organization, or United Ostomy Associates of America is an organization that provides support and education for patients. This is a good ready resource if you're seeing someone and you don't have the resource of an ostomy nurse. You can go to this site, uoaa.org. They've got support groups listed for any area, so you can find a support group for your patients. You can find patient education for any type of ostomy problem you can think of. They have a forum on there where ostomies can talk to each other. And then links to many other resources as well. So that's a good resource to have in your handbook if you don't have ready resources by. And the rest for references. And that's Boomer. That's my cat. Is there any questions about, any concerns you have about ostomy care?
I have one difficult case, and I think what makes the life of this patient worse is everybody saying there is nothing, this is not a problem. You know, family can be so happy that your loved one is alive because you survived cancer or something like that, that they minimize so much it hurts also. because it's not normal. You can live with it, adapt and cope, but everybody, in this case, everybody telling her that this is nothing doesn't help her overcome her depression, because the family always said, oh, this is nothing, they are so happy she's alive, but it continually hurts her that she never overcomes her depression and so forth. So yes, this is something hard, but you can live well with it if you put up with it and learn how to do it. So minimizing totally the problem doesn't help either.
No, absolutely not. You need to kind of hit it head on. You need to, like with concerns like sexual and intimacy, you need to give them permission to talk with you about it. Because that's not something, especially in the elderly group, that's something that they're comfortable approaching. You have to give them permission. You have to sometimes make the introduction. Oftentimes, and this was something that I found with my mother, which, at the time it was very irritating, but she would complain to me about this and that and this, and I'd take her to the doctor, and she'd sit down, and the doctor would say, oh, how you been, Dorothy? And she'd say, oh, I'm fine.
They all do that.
So you kind of, at this, so you get a call from the family, or the family brings them in, you kind of got to pull it out of them and address it. Oftentimes these things aren't addressed, and that's part of the problem. Or because someone's saying, oh, you're alive, don't worry about it. But you're laying in your bed at night thinking, these horrible thoughts.
The first ostomy patient I had.
I'm sorry, any question from the audience out there? Yes.
We had a question before.
I'm sorry? Can you repeat?
Do you suggest using the tablets, and if so, which ones?
Tablets for odor?
For odor?
They have some tablets for odor. I can't think of the name of them. They've got chlorophyll tablets. You can talk to them about food choices, and there's some foods that make things stink and not. But there's gels, there's pills you can put in your ostomy bag, there's liquid neutralizer, there's, and they're coming out with new things every day. But I really have not had a lot of success with the internal pills, as far as patients being compliant with it.
I work for hospice, and I just wondered if it's because they're, quote, terminally ill, if it's different, or if...
No, if they're having, a lot of odor problems and the deodorizers aren't working, sometimes yogurt, if you can get things like yogurt and lactobacillus in them, sometimes that can help. Buttermilk can help with odor control, trying to change the smell of what's coming out.
Thank you.
Any other questions?
Not so much a question. The first interaction I ever had with an
I'm
ostomy
sorry.
patient in a nursing home, he spoke Spanish, might have been some dementia.
Mm-hmm.
But this particular day, his bag was quite swollen. Now, I don't know if it was overfull or if it needed to be burped, but he went to the nurse's station. See, I need to be fixed. Later.
Oh.
They kept putting him off, and whether it exploded or he took it off, I don't know what happened. But it came loose. The whole building smells.
No.
And then the nurses want me to talk to him about his behavior. And it's like, no, that's not the behavior problem.
Oh, we missed the ball somewhere, didn't we? Most definitely. Yes.
I think this patient who's gonna go for colostomy and ileostomy, do they get education before, during, and after about taking her colostomy? Whether they have support systems? Because if they live alone and they are frail, they won't be able to do it on their own. I've seen that happen all the time.
Well, it depends on the surgeon. Now, I work closely with urology and colorectal surgery, and they send all their patients to me for pre-op. I actually do a pre-op counseling, pre-op teaching, explain their surgery, explain what it's going to be like living with an ostomy. That's really what they want to know. Am I going to get my life back after this? And I also mark where the stoma is going to go. So they come to me for an hour session for pre-op education and site marking for their ostomy. And the reason that the ostomy nurse does that is because the ostomy nurse knows the products and how to avoid problems as far as siting a stoma. So yes, and they get education ahead of time if they're open to it or they have the ability. I give them resources to look up if they want more in-depth education. I have kits that they can go home and practice ahead of time, and if they're open to it, I encourage that, because the more you know before surgery, the easier it is to learn your care after. Not everybody's open to it. Someone will go in and say, I don't want to know anything until I got to know it, and shut you right down. So, you kind of got to go with what they're ready for. Sometimes they got to take it in bits and pieces in order to cope with it. Because again, preconceived notions of what they think it's going to be and the problems they're going to have. So
from what she had said about the lesion, do you have any kind of supplies to avoid this? Something that would protect the skin around the area?
for ileostomies,
The stomach acid would make it worse. It would create skin irritation.
what, well, I'm sorry.
Stomach acid powder.
The stomach powder is used to treat skin breakdown once it occurs. Sometimes they get out into the field and people, because it's in their arsenal of tools, and that's ordered for them because, you don't want to have to wait and call for a prescription and get supplies in, when it happens. You need to have that tool in your kit. And then what will also often happen, they go home and they've been taught, and they've got step-by-step directions in their education folder how to do, but then they go, and then the home care nurse says, no, you got to use it every time. And then that creates problems in itself, because the ostomy products that are made now are made to go directly on the skin. So the less you have between the ostomy pouch and the skin, the better adherence you're going to get. But those old practices die hard, because you might have a nurse in home care that was there 30 years ago when she had to put rubber cement and layer ostomy powder and ostomy paste and rubber cement and to get it to stick, and those old habits die hard. Even with ostomy patients who had long-term, because that's one of the challenges I sometimes get. They're having problems with their new pouch, and I've been using paste and Torbot Bond and all this for years, and why isn't it working now? Well, because if you read the insert in the package, it says do not use with skin barrier film, blah 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 blah, because the products have changed, and oftentimes you take some coaching to get them to that point where they'll let it go naked, because that's what it feels like to them. What? I don't have my glue and my paste and my window of tape, and sometimes they come in and they've got tape out this much, because not because they've leaked, but because they're afraid of leaking. So and then once I get them to the point where they'll try it and it stays on for 5 days, they're like, what? And they can't believe it. So you have to match the pouch to the ostomy and the body type. There's different, if you have a big round firm belly, the two-piece pouches are too rigid and they kind of want to pop off. Or if you have, valleys and ridges, you need something flexible and it's going to move with you. Or you may need a belt to wear with it to keep it a little snugger to you. So now the hospitals don't always carry all those things. But what ends up happening is the ostomy supply companies are very good about giving you samples. So if you think something's going to work with the patient, you order them samples, you educate them how to use it, and you do a trial. If that works and they're getting good wear time, then we change the prescription and supplies over. And the supply companies will let you do that as much as you need to in order to get the patient fitted into the appropriate appliance and get their quality of life back. So, and then there's ways to simplify things. There's different, if they have dexterity problems, there's different types of clamps. Once their stoma's healed, you can order pouches that are already cut to that size so they don't have to worry about cutting them out. They just take the old one off, clean the skin, peel it, and pop the new one on. So those are type of things that we look to do to simplify their life and get them back confident and back to their activities. Anything else?
Well, we need to wrap this up, but that was
Very good.
Thank you.
Thank you.
Very good. Okay, we have evaluation forms. Please fill them out if you have any questions for your CD. Erica can help you out there at the table. Thanks for coming. See you next month. Great. Thank you very much.
Thank you.